Very good evening to respected seniors and my dear colleagues. First, let me congratulate Sumiskan for arranging this CME today. This evening, we are having two beautiful and interesting topic which is very pertinent across all the discipline of medical science. And we have two excellent speakers who will be speaking on these two topics. And the whole event will be chaired by none other than Dr. T.K. Halder, who needs no introduction to you. He is a senior physician practicing in Malda. And I am handing over the charge of this session to Dr. T.K. Halder. Sir, please. Thank you.
Good evening, everybody. At the outset, let me thank the organizer of this seminar because of two reasons mainly. One, for inviting me to chair the session. It's a huge honor for me. And secondly, selecting the topic of today's topic is very important but neglected topic, that is antibiotic stewardship and antimicrobial resistance. Though the term antimicrobial resistance has been given, as you all know, microbes are divided into different categories: bacteria, virus, fungus, and parasites and others. I presume our talk will be restricted mainly to bacteria. As you all know, as you all aware, that the invention of germ theory of the disease with the work of Louis Pasteur and Robert Koch is a great milestone in the history of medical fraternity, and after and it's a landmark discovery. Infectious disease caused by these microorganisms threatened human life for time immemorial. As you all know, during pre-antibiotic era, the major concern of mortality is due to infection, but with the with the discovery of penicillin, the first antibiotic in the year 1928, and with its clinical use in the year 1943 during World War II, actually it's a revolution in the combating infection from different organisms. In next 3 decades, up to 1980s, there are several antibiotics were invented, and as you all know, after 87 till date, there is not much discovery of antibiotic, and usually this is called discovery void period. But with irrational use of these antibiotic, self-medication, misuse of antimicrobials, emergence of antimicrobial resistance is there. And as you all know, this is main reason of discussion today, and it has been estimated that up to 50% or more use of antibiotic in different health setup, in especially hospitals, is found to be inappropriate. And as you all aware, that nowadays antimicrobial resistance is increasing. About more than 50% of Klebsiella pneumoniae is resistant to carbapenem, and more than 50% of E. coli causing UTI is resistant to fluoroquinolones, and it is known fact that methicillin-resistant Staph aureus is major cause of mortality in more than 64% of the patient, and this is true for other infection also like cholera, and enteric fever also. As you all know, enteric fever is nowadays about 70% resistant to quinolones. And same is true about tuberculosis. As you all know, now we are in a phase of tuberculosis, national tuberculosis elimination program. There is actually previously when we used to treat malaria, there are 3 categories we used to divide: Cat 1, Cat 2 and Cat 3. Nowadays only two categories are there. One is drug sensitive group of patient and another is drug resistant group of patient. Such is the volume of the problem is there. And a survey, national anti-tuberculosis drug resistance survey was there, and with the cooperation of World Health Organization and India, Government of India, during between 2014 and 2016, they studied on 13 anti-tubercular drug, and it was found that multi-drug resistant tuberculosis incidence was 6.19%, of which almost 3% is new and almost 12% among the previously treated tubercular patient. Among the MDR tuberculosis, that is multi-drug resistant tuberculosis, about 22% resistant for fluoroquinolones and 3.5%, that is about nearing 4% on second line injectable anti-tubercular drug. And so for decades the microbes has been used with irrationality, and first in 2015 World Health Assembly endorsed a global national plan on antimicrobial resistance, and it recognizes antimicrobial resistance as a global threat to public health. And this policy initiative acknowledges the overuse and inappropriate use of antibiotics as a global threat, and thereafter this antibiotic stewardship came in force, and we will talk on this. I will start this on this today. We have two topics today. One will be antibiotic sensitivity pattern and best practices in antibiotic stewardship, and second one will be on MDR and XDR tuberculosis. And let me start with the first topic, and it's my pleasure to invite Dr. Sanjeev Kumar, who will speak on antibiotic sensitivity profile and best practices in antibiotic stewardship. Dr. Sanjeev Kumar, please. Screen is off.
Good evening. Today I am going to discuss the antibiotic sensitivity profile and best practices in antibiotic stewardship. What is antibiotic stewardship? It is the optimal selection of antibiotic dose and duration so as to get the best clinical outcome and with minimal impact in subsequent resistance. So whenever we are treating a patient for infection, we should have two goals. One is that our clinical outcome should be good, the patient infection should resolve, but side by side our next goal should be to administer antibiotics in such a manner that it do not impact on the antibiotic resistance. So the antibiotic resistance has to be checked. This is antibiogram. This is something we prepare every 6 months in solar scan. What we do, we gather the data of all the isolates which we are getting in our department, and we analyze them to form the antibiotic sensitivity pattern or the antibiogram. This is the first slide of that antibiogram. It is distribution of isolates in urine sample, means what all isolates we have got in the period of July to December 2021. The total number of isolates were 340, out of which the most common isolate was E. coli, followed by Klebsiella, followed by Pseudomonas and Acinetobacter. Then also we have got some organisms in small numbers like Staph aureus, Staph subophyticus, Enterobacter, Proteus, Cytobacter and Morganella. So the key point is, E. coli is the most common organism in urine, followed by Klebsiella. This is the distribution of isolate in non-urine samples, basically pus and bone swabs, sputum, eye swab, these samples. And here the most common organism isolated is Staph aureus, followed by E. coli, Pseudomonas acinetobacter, Klebsiella. So here the key point is the most common organism for bus sample is Staph, but gram-negative organisms do also have a influence in forming the antibiogram. So then this is the antibiotic sensitivity of different antibiotics against gram-negative organism in urine. For the ease of categorization, for ease of understanding, I have divided the antibiotics into three categories. Color codes. One is red. Red is given to those antibiotics whose sensitivity has decreased to less than 50%. The antibiotics with less than 50% sensitivity are in red in color. The antibiotics with 50 to 80% sensitivity are yellow in color, and the antibiotics with more than 80% sensitivity are green in color. So the antibiotics with sensitivity less than 50% are ampicillin, ticarcillin, amoxiclav, and that amoxiclav is 41%, less than 50%. Then ticarcillin, clavulanic acid, cephalosporin, cefuroxime, ceftriaxone, cefixime, cefuroxime actinium. Basically, the cephalosporins are having very less sensitivity. Then your fluoroquinolones, ciprofloxacin, norfloxacin, ofloxacin, they have got very less sensitivity of less than 50%. The antibiotics with 50 to 80% sensitivity are ciprofloxacin, sulbactam, piptaz, cefepime, imipenem, meropenem, cotrimazole, and nitrochlorantine. So you can see even imipenem and meropenem do not have a sensitivity of more than 80%. Their sensitivity is around 60%, and the nitrochlorantine sensitivity is 67% in urine samples. Again, this is the sensitivity of gram-negative organisms in non-urine samples, basically pus and bone swab. Here, the antibiotics with less than 50% are ampicillin, amoxiclav, ticarcillin, clavulanic acid, cefuroxime, ceftriaxone, cefuroxime actinium, ciprofloxacin, and levofloxacin. So basically, when you are going to treat pus samples in and you have gram-negative organisms in focus, and you are going to give amoxiclav, then you see what the sensitivity is 22%. If you are going to treat it with cefuroxime, what is the sensitivity is just 23%. Means in rest of the cases it will not work. And the organisms with, the antibiotics with 50 to 80% sensitivity are ciprofloxacin, sulbactam, paclitaxel, cefepime, artepenem, imipenem, meropenem, amikacin, gentamicin, cotri, and tigecycline. And there is only one antibiotic in this category which is having a sensitivity of more than 80%. That is only colistin. So this is a very poor situation. Colistin is having antibiotic sensitivity of 100%. In urine also, I forgot to mention, in urine also, colistin is, I have not written here, but colistin is 100% sensitive in our institution. And this is the sensitivity of gram-positive organisms, which are isolated from pus, wound swab, etc. Here, penicillin V is 3.5% only sensitive. Oxacillin is 37%. Okay, oxacillin. Why oxacillin is given? Oxacillin is a surrogate marker for methicillin-resistant Staphylococcus aureus or MRSA. So by this chart, what we can see that oxacillin is resistant to 62, is resistant in 62%, means MRSA in our prevalence in our hospital is 62.7%. Then Cipro and Levo, we see the sensitivity 5% and 4%, almost gone. Clindamycin 36%, erythromycin 15%. So, antibiotics with 50 to 80% sensitivity are gentamicin and cotrimazole. And there are many antibiotics which are narrow spectrum, which are used only for gram-positive organisms. These are having good sensitivity for now, like daptomycin, linezolid, vancomycin, teicoplanin, they are having 100% sensitivity. Okay, so as I said that we in our hospital make this antibiogram every 6 months. So I have put a comparative data of what was the pattern in last year and what is the pattern in this year 2021. So for the ease of comparison, again I have classified them into 3 color codes. green color code is represents those antibiotics whose sensitivity has increased by more than 5%. So there is the antibiotics with significant increase in sensitivity, I have marked them green. The antibiotics with more than 5% decrease in sensitivity, they are marked in red. Their sensitivity has decreased to a significant level, and the antibiotics with very less change in sensitivity are marked in yellow. So I will be discussing only red and green one. The antibiotics with decrease in sensitivity are this is in gram-negative urine samples. Decrease in sensitivity is ciprofloxacin. The sensitivity has decreased from 28 to 12%. Ciprofloxacin acetyl, same 28 to 12%. Artepinim, 87 to 81%. Ofloxacin, 45 to 37%. And nitrofurantoin. You see the sensitivity of nitrofurantoin has decreased from the last year to this year. The sensitivity of nitrofurantoin has decreased from 76 to 67%. This is a huge decrease. The antibiotics which somewhat increase in sensitivity are ciprofloxacin sulbactam and dicasine chemical acid. Okay, this is a comparison of antibiotic sensitivity in pus sample, gram-negative organisms. Here, many antibiotics have got a decreased sensitivity from the last year. The pattern is varying. Amoxiclav, it was earlier 38%, now it is 22%. Ciprofloxacin sulbactam, dicasine chemical acid, cibipine, ciprofloxacin acetyl, imipenem, meropenem, Amica, Genta, Cipro, Levo, all antibiotics, all even ticacycline, all these antibiotics are showing a downward trend, their resistance is increasing. And the antibiotic with increasing sensitivity are ceftriaxone and cotrimoxazole. Cotrimoxazole has increased significantly from last study, 51% to 66%. And this is for gram-positive. Here, clindamycin sensitivity has decreased from 58 to 36%. And luckily, we have got this oxacillin, which is the surrogate marker for MRSA. So in our setting now, MSSA is message sensitive staph. Earlier it was 26%. Now in this diagram it is 37%. And also gentamicin is increased from 43 to 59%. So this was the gist of our antibiogram. Now I will discuss the type of antibiotic resistances. You will say, okay, why should I know the type of antibiotic resistances? You are a microbiologist, you should know all these things. Why a clinician require all these things? I will answer this question. Why you should first you see the type of antibiotic resistances which are commonly encountered. Then I will tell you why everyone should know this. These are the two resistances which occur in gram-positive. Out of this, MRSA stands for methicillin resistant Staphylococcus aureus. These organisms are considered resistant to penicillin, cephalosporin and carbapenems. So if I am writing, I have isolated MRSA strain, that means I am telling you directly that no, your amoxicillin is not going to work, your meropenem is not going to work, your cephalosporin is not going to work, because it is MRSA strain. So the drug of choice for MRSA strains are vancomycin and teicoplanin, and linezolid can be used to treat skin and soft tissue infections caused by MRSA. Then second is VRE, vancomycin resistant enterococci. They are not that common in our setting, but still enterococci is a therapeutic challenge because it has got a lot of intrinsic resistance. But in this situation, vancomycin is the drug of choice. But if an enterococcus gets resistance to vancomycin, it becomes a very difficult situation to treat. That's why this is very difficult to treat, vancomycin resistant enterococci. And these are for gram-negative. The first one I didn't write is penicillin H. They are penicillin, the monospectrum penicillins will be resistant. The second one is ESBL producing interbacteriacin. What is this? ESBL stands for extended spectrum beta lactamase. What are these? These are the organisms which produce this enzyme which is plasmid mediated, and if an organism is ESBL producing, what will happen? They will be resistant to cephalosporins, penicillins as well as aztreonam. So basically your penicillin and cephalosporins are resistant. So in your profile you will get say ceftriaxone as a proxy resistant, but they are inhibited by BLPLI. BLPLI are beta-lactam inhibitors. So if you are getting a profile where ceftriaxone is resistant but your pathogen is sensitive, you are most probably dealing with ESBL organism. They are often multi-drug resistant because this plasmid include resistance to aminoglycosides, fluoroquinolones, and cotrimoxazole also. They may also be resistant. And what is the treatment available for serious cases? Our treatment of choice is carbapenems, and for mild cases, our treatment you may consider peptide or sulfonylurea for treatment. Okay, the next is MC. They are resistant to penicillin, cephalosporin, and BLBLI. What I said in my last class, in my last slide, they are resistant. ESBLs are resistant to penicillin and cephalosporins, but BLBLI they are sensitive. Here, penicillin, cephalosporins, and as well as BLBLI are resistant. So these organisms, there is a phenomenon called inducible MC. What is that? There are certain organisms who are notorious to exhibit this type of mechanism where when you do a culture, the culture will show sensitivity to beta-lactam antibiotics, but when you start the treatment, in the course of treatment, the bacteria will develop resistance, and these organisms are these are space organisms. Space stands for Serratia, Providencia proteus, Acinetobacter, Citrobacter, and Enterobacter. So if you are dealing with, if you get such report and you are seeing that okay, it is beta-lactam sensitive, you should think that maybe it is a MC producer, because these organisms are notorious of producing this inducible MC. Then next type of resistance is carbapenem resistant Enterobacteriaceae. They are resistant to, they are carbapenemase producers. The carbapenemase enzyme in part resistance to penicillin, cephalosporins, BLBLI, and carbapenems. So you see there is a hierarchy. First ESBL was resistant to cephalosporins and penicillins, but it was inhibited by BLBLI. And then MC was sensitive, resistant to cephalosporins, BLBLI, and penicillins, but it was sensitive. It was hit by carbapenems. And carbapenem, then these carbapenem resistant Enterobacteriaceae, they are resistant to penicillin, cephalosporin, BLBLI, as well as carbapenems. Here the treatment option which remains is polymyxin and tigecycline, also aminocin, also means aminoglycosides. Tigecycline is licensed for complicated skin and soft tissue infection and complicated intra-abdominal infections. But tigecycline has low blood and urine concentration, so we should not use tigecycline in bloodstream infection as well as UTI. Their role is limited to one skin and soft tissue infection and complicated intra-abdominal infection. Okay, this is an exercise of what I have said just now. First one, you see all the antibiotics are sensitive, so this is a wild type without any resistance. The second one, this is only ampicillin resistant, all other are sensitive, so this is a penicillinase. The third one, you see ceftriaxone is resistant and your peptide is sensitive, so this is ESBL. The fourth one, ceftriaxone resistant as well as peptide resistant, but meropenem is sensitive, so this is MC. And the final one, all are resistant including meropenem, only sensitive is polystyrene, so this is carbapenemase. So by this simple chart, you may guess what sort of resistance is exhibited by the organism which you are seeing in the culture report. Now, how to utilize this? The thing is that when we are treating a patient, there are 2 points where we decide as to analyze what antibiotics should be given. The first point is when patient first comes to you, you don't know what sort of infection you will encounter, you give an antibiotic blindly. This is empirical antibiotic. And the second is when you give the antibiotic after you get the culture report. So before you give the antibiotic, empirical antibiotic, what you should do, you should type the patient as to type 1, type 2, type 3, type 4. Type 1 patients are those patients which have very less chance of getting a multi-drug resistant organism. And type 4 patients are those patients which are having a very high risk of getting multi-drug resistant organisms. So if you know what type of patient you are dealing with, you can select the antibiotic accordingly. So type 1 patient is those patients who are having no contact with the healthcare system, no prior antibiotic therapy in last 90 days, no risk, no comorbid condition, and they are at minimal risk of MDR pathogens. You may guess that okay, the pathogen may be a wild type. So, and invasive fungal infection is unlikely. Type 2 patients are those patients who have contact with healthcare system, like recent hospitalization, hospital admission without any invasive procedure. They have antibiotic therapy in last 90 days. They have few comorbid conditions. And what you can guess that okay, this is type 2 patient, so I may get an ESBL or a MRSA. I may get an ESBL and or a MRSA, so I can give antibiotic accordingly. There is no risk of invasive fungal infection. Type 3 patients are those patients who have hospitalization for more than 5 days and infection following invasive procedures. They have recent and multiple antibiotic therapies. They have multiple comorbidities like cystic fibrosis, neutropenia, and other immunodeficiencies. These patients are at high risk of multi-drug resistant pathogens like ESBL, MRSA, as well as non-fermenters. What are non-fermenters? Non-fermenters are nothing but Pseudomonas and Acinetobacter. And we all know that Pseudomonas and Acinetobacter are very notorious of having a multi-drug resistant profile. So in type 3 patient, you will be encountering these organisms. And there is a risk of invasive fungal infection in special cases like a patient undergoing allogenic bone marrow transplantation, chemotherapy-induced neutropenia. Then type 4 patients, they are type 3 patients with fever despite antibiotic therapy for greater than 5 days with no obvious source or after source control. So they are having antibiotic for more than 5 days, but still fever is not subsiding. They may have severe sepsis or septic shock. They have factors for invasive fungal infections like TPN, hemodialysis, multifocal candida colonization, and diabetes. These 4 patients are at increased risk of pan-drug resistant organisms. Means you can get ESBL, MRSA, non-fermenters, as well as carbapenem resistant Enterobacteriaceae, and they are at high risk of invasive fungal infection. So if you diagnose the patient at the first time when you see the patient, you can guess what sort of antibiotic resistance you will encounter when you get the culture report. So, and you can analyze it and you can decide the empirical treatment protocol. In type 1 patient, what I said, you will guess that okay, I may get a wild type. So there is limited use of broad spectrum antibiotic and no role of antifungal treatment. Type 2 patient, what was that? What was there? They were at increased risk of ESBL and MRSA. So you will give your empirical antibiotic accordingly. ESBL infection is to be treated with non-pseudomonal antibiotic. Why non-pseudomonal? Because Pseudomonas comes into play when there is type 3 patients. We will guess the presence of Pseudomonas in the infection when there is type 3 patients. So we will try to avoid anti-pseudomonal drugs here. So non-pseudomonal antibiotics like group 1 carbapenem, that is ertapenem. Ertapenem is non-pseudomonal carbapenem. BLBLI can be given in mild ESBL infections. Vancomycin and teicoplanin can be given for MRSA. No role of antifungal agent. Then if it is type 3 patient, what was there? You may get ESBL, you may get MRSA, you may get non-fermenters, and you may also get invasive fungal infection in very selected cases, not in all cases, in selected cases. So here, what should be your empirical treatment protocol? It should cover all these organisms, and bacterial infection to be treated with broad spectrum antibiotics like carbapenems or anti-pseudomonal BLBLI in combination with other agents like fluoroquinolones and glyphosate and glycopeptides. And prophylaxis of fungal infection in selected case as per IDSA guidelines can be given. Then type 4 patients, here what sort of antibiotic relationships were there? ESBL, MRSA, non-fermenters, as well as carbapenem resistant Enterobacteriaceae. Along with that, invasive fungal infection, there was a increased risk of invasive fungal infection. So as they are carbapenem resistant, so bacterial infection, how to treat those cases which are having which are only colistin sensitive, they are having carbapenem resistant profile. Dr. Sudhanshu Mandal will be dealing with this in detail. I am not going in detail. So there is novel combination of antibacterial which are given for such organisms, and empirical treatment should include antifungal therapy post for stable and unstable patient as per IDSA guidelines. So this is how we should utilize the typing concept and what antibiotic resistance we can encounter, and what based on that what empirical therapy we should give. Now after giving the empirical therapy, after 2 days, after 48 hours, you get the culture report. So what we do, we practice these 2 things: continue the treatment and escalation, continue the treatment when the patient is stable and you see the, okay, what antibiotic I have given, it is susceptible, okay, I will continue the therapy. I will escalate the therapy when the patient is not responding, or the antibiotic, the culture report is saying that, okay, the antibiotic which you have given is not appropriate, you have to move upwards. So these 2 things we do. What we do not do, or what we should rather do, is, means these 2 things are okay, but we should try to focus on de-escalation. De-escalation means when you have started an antibiotic, suppose you have thought that, okay, this is a type 3 patient, I am going to give a carbapenem. You have started antibiotic, carbapenem, and after 48 hours, you see that, okay, my culture report says that this is your organism which is sensitive to carbapenem tazobactam also. So after 48 hours, when you get the culture report, you can actually de-escalate, and you should actually de-escalate. This will help a lot to prevent the higher antibiotic from getting resistant. So this is the key to antibiotic stewardship, de-escalation. Okay, this is well-known concept, pharmacodynamic character, concentration dependent and versus time dependent. Those antibiotics which are concentration dependent, like aminoglycoside and fluoroquinolones, their peak serum concentration is associated with efficacy, so you should give them in higher dosage. And those antibiotics which are time dependent, like beta-lactams, their serum concentration should exceed MIC for the duration of dose interval. So we should try to give them in continuous infusion or frequent dosing. Okay. Now these are the guidelines which I have picked from CDC. CDC, what guidance they have given, they say that we are overusing antibiotics in our day-to-day OPD setting. So they have given guidelines as to how we can actually decrease the overuse of antibiotics in day-to-day infections. This is adult guidance. There are also pediatric guidance. The first is acute rhinosinusitis. The epidemiology says that 90 to 98% of rhinosinusitis are viral in nature, and they do not require any antibiotic therapy. When to give antibiotic in such cases? In case of bacterial rhinosinusitis. And how to diagnose the bacterial rhinosinusitis? The diagnosis of bacterial rhinosinusitis is based on symptoms which are severe, persistent and worsening. Severe means greater than 3 to 4 days of fever, greater than 102 degree Fahrenheit, and prevent either discharge or facial pain. Persistent means greater than 10 days without improvement. Greater than 10 days without improvement of major discharge and daytime cough. And worsening means worsening after initial improvement of a viral upper respiratory tract infection. What is the management? If bacterial infection is established, if it is a viral infection, you do not need to give an antibiotic. If bacterial infection is established, then vascular waiting is encouraged for uncomplicated cases. If you have to give antibiotic, then amoxicillin or amoxicillin in the first line of therapy. For penicillin allergic patients, doxycycline or levofloxacin are recommended. Alternate agents. Macrolides are not recommended due to high level of resistance. Then secondly, is acute uncomplicated bronchitis. Acute bronchitis is the most common diagnosis in adult patients with cough who visit the primary healthcare provider. Here also, routine treatment of uncomplicated acute bronchitis with antibiotics are not recommended, regardless of the duration of cough. The duration should focus on ruling out pneumonia. And these points also say that you have to give the antibiotic according to the typing of the patient. Having high risk, if it is high risk, then you have to give more antibiotic, higher antibiotic. If it is low risk, then you should give low antibiotic. And what the main thing is that Procal, they have defined the role of Procal. They say that Procal should not be used to decide when to start the antibiotic. Procal should not be used to decide when to start the antibiotic. It should be used to decide when to discontinue the antimicrobial. That too, when we are using Procal for decision making when to discontinue antimicrobial, it should be used as an adjuvant with the clinical evaluation. So your clinical evaluation along with Procal can be used to decide when to discontinue the antimicrobial, but it should not be used to decide when to start the antimicrobial. Now I will do some tell you something about blood culture, because sepsis is largely under-recognized as a major cause of morbidity and mortality worldwide. These are the indications for blood culture. This is you all clinicians, you know better than me. I am skipping that. So when should blood culture be collected? Blood culture should be collected as soon as possible after the onset of clinical symptoms, ideally prior to the administration of antibiotic. And what to do if the antibiotic is already given? If the patient has already received an antibiotic, then collect the blood immediately before administration of the next dose. So collect the blood immediately before the administration of the next dose if an antimicrobial therapy has already been started. What volume of blood is to be collected? This is very important. I want to make it very clear because this is very confusing. What volume of blood is required? You see, when we say a blood culture set, it means aerobic as well as anaerobic. So we have two blood culture bottles. One is for aerobic and one is anaerobic. When you say that, okay, give me aerobic plus anaerobic blood culture report, I will have to take blood for aerobic culture bottle and anaerobic culture bottle. And aerobic culture bottle will require 10 ml, anaerobic culture will require additional 10 ml. So one culture set will require total 20 ml of blood, and we require 2 to 3 such sets per septic episode. So 20 ml per set, 2 to 3 sets means 40 to 60 ml. So why such a huge volume of blood is required? Because the volume of blood per blood culture set is the most significant variable in recovering microorganisms from patients with bloodstream infection. So we require high amount of blood to get a most reliable report. What about children? In children we cannot take so much amount of blood. So the amount of blood we require in children is based on the weight. If it is greater than 36.3 kg, you have to take blood according to, as it is taken in adults. If it is then according to the weight, you can take 5 ml, 2 ml or 1 ml depending on the weight of the patient. If at all you have a problem with collecting the blood, if you have to avoid something, avoid anaerobic culture. Anaerobic culture as a cause of sepsis is not that much important. You should, if you have to discard something, you can discard anaerobic. You should always try to prioritize aerobic culture. Now, why do we require 3 sets? I am told that 3 sets per septic episode is taken. Why is it so? Because the number of sets of blood culture we are taking is directly proportional to the detection sensitivity. If we are taking 1 set, our detection sensitivity is 73.1%. If we are taking 2 sets, detection sensitivity is 89.7%. If we are taking 3 sets, the distinction sensitivity is 99.3%. It means if you are giving only one set of blood culture, if you are prescribing only one set, then there are 27% chance that you will miss the pathogen. The pathogen will not grow. So that's why collect 2 or preferably 3 blood culture set per episode of sepsis. What is the guideline for infective endocarditis? Initially take 2 to 3 blood culture set and wait for 24 to 48 hours, and if there is negative growth in after 2 to 3 in 24 to 48 hours, you have to take additional 2 to 3 blood culture sets in case of infective endocarditis. Okay, when we give a report of the blood culture, say we have isolated some organism from in the blood culture, I want to make it very clear that mere the isolation of an organism from a sample does not establish its pathogenicity. There are contaminants, there are colonizers. Suppose I am taking blood, and here at the site of blood culture where I am taking the blood, there were some coagulation negative staph which were present at the site of skin where the venipuncture is done. What will happen? This organism will go into the blood culture bottle and it will grow. So it will give a false impression that there is a pathogen, but actually it will due to contamination. So we have to understand that what is which isolate is a contaminant and which is a pathogen. So very simply, if you are giving more than one blood culture set, then if a pathogen, established pathogen like E. coli or Staph aureus is grown from even a single blood culture bottle, it is pathogenic. But when you isolate something with a questionable pathogenicity like coagulation negative staphylococcus, then you have to think whether it is a pathogen or a contaminant. So here what we should see that whether it is isolated from one culture bottle or it is isolated from more than one culture bottle. Repeated isolation of a organism with a questionable pathogenicity makes it a pathogen. Means the same organism you are isolating from 2 different sets. That means it is likely to be a pathogen. But if you are isolating coagulation negative staphylococcus in just one blood culture and the other cultures are negative, you will think that most probably it is a contaminant. Okay, this is my last topic, colonization versus infection. So as I said, mere the isolation of an organism does not mean that it is pathogenic. There are clues from the laboratory findings, there are clues from clinical findings which will suggest whether the organism isolated is a colonizer or infection. Dr. Subhanshu again will be describing this in detail. First is if you are getting a organism from a healthy granulating wound with normal tissue, the wound is healing, still you are getting some isolate, it is probably a colonizer. But if you are isolating a organism from a bad looking wound, it is most really pathogen. Then in urine we all know there is a colony count concept, greater than 10 to the 5. If it is less than 10 to 5, its pathogenicity is questionable. And one thing, asymptomatic bacteriuria. I want to make it very clear, asymptomatic bacteriuria should not be treated. Routine treatment of asymptomatic bacteriuria means you are getting bacteria in urine without any symptoms. It should not be treated. There are only 2 indications when you should treat asymptomatic bacteriuria. One is when the patient is pregnant or when the patient is requiring any urological procedure. Otherwise, asymptomatic bacteriuria should not be treated. Data should not be investigated. Okay, just like there is colony count concept in urine, there is also colony count concept in respiratory tract specimen for the diagnosis of ventilator-associated pneumonia. Here, the significant colony count for tracheal respiratory is greater than 10 to 5, for bronchial lavage is greater than 10 to 4, for protected brush specimen is greater than 10 to 3. And when I am reporting sputum, whether the organism isolated is a pathogen or not, I have to give a Q score Q score is generally based on two factors: what is the number of pus cells and what is the number of epithelial cells. If the number of pus cells per high power field is more than the number of epithelial cells, it means it is not a sputum, but rather it is a saliva. And any organism isolated from such sample, its pathogenicity is really questionable. Then, if the patient is has already received multiple antibiotics and patient has no compatible symptoms, still you are isolating bacteria, it is likely to be a colonizer. Candida is frequently isolated from bronchial lavage and sputum in patients who are treated with multiple antibiotics. They are colonizers. They should be considered colonizers. And there are organisms of questionable pathogenicity like Foreign negative staph, non-tubercular mycobacteria in the spaghetti sample, and Candida. But there are certain situations where they should be considered true pathogen. Like I said, in cons, if it is repeatedly isolated from blood, especially in presence of a foreign device, it should be considered pathogenic. The non-tubercular mycobacteria, if it is isolated from in respiratory sample from patient with compatible symptoms with immunocompromised or COPD, it should be considered pathogenic. And Candida, generally, if it is isolated from urine, it is not considered pathogenic, it is a colonizer. But if it is isolated from urine in immunocompromised patient or a diabetic patient with symptoms, it should be considered pathogenic. But in blood, Candida is a pathogen. Even a single blood culture positive, if it is positive, then it is pathogen. Candida should always be considered a pathogen if it is isolated from even a single blood culture bottle. And if you are treating the patient effectively, if you are giving effective systemic therapy, but still the organism is persistently isolated, it should be considered colonizer, and there is no need for treatment of such patients. So thank you. With this I end my.
Thank you, Dr. Kumar, for your excellent and erudite